all. I'm here to present a case report of migrated Ozurdex implant. On January 23, 2023, a 63 years old male patient came from Salem with chief complaints of defective distant vision in the left eye for the past 1 week. History of presenting illness. The patient, who was apparently normal before 1 week, has developed defective distant vision in the left eye, which was sudden and onset, progressive in nature to reach the current state. There is no history of recent trauma and redness, no history of floaters and flashes, no history of transient loss of vision. Past history, patient is a known case of type 2 diabetes mellitus and hypertension for the past 8 years under regular medications. He is not a known case of asthma, TB, hypothyroidism, COPD, CVS, and other blood dyscariasis. Past ocular history is a known case of left eye proliferative diabetic retinopathy, status post PRB stable status. Left eye ranibizumab injection was given on 27 September 2022. Left eye Ozurdex intravitreal injection was given on 7th December 2022. All procedures were done in Aravind Hospital, Coimbatore. Patient had history of loss of vision in the right eye after blunt trauma 20 years back. Past surgical history of left eye SACS done 4 years ago, 2017, in Aravind Hospital, Coimbatore. History of intro complications data could not be found, and personal and family history were found to be nil significant. General physical examinations, vitals, and systemic examinations were found to be normal. Ocular examination, head posture and facial symmetry is normal. Visual acuity in the right eye shows the best corrected is nil perception of light. In the left eye, the best corrected visual acuity is 6 by 36, and for near vision, plus 2.5 dioptric sphere at 33 centimeter. IOP is 25 millimeter of mercury measured by Goldman applanation tonometer. Right eye shows eyelid adnexon conjunctiva was normal. Cornea shows 6 into 5 mm central leukomatous corneal opacity. On left eye, eyelid adnexon conjunctiva was normal. Cornea shows 2 plus epithelial edema with multiple DM folds all over the cornea. Anterior examination shows 6 mm rod-shaped mass seen floating from 5 to 7 o'clock position, which is suggestive of migrated Ozurdex implant. Iris is normal color position. Pupil shows 3 mm round triangular reacting to light, which is with the normal direct light reflex. Lens shows PCI1. This is an anti-segment photograph of the patient with the migrated Ozurdex implant taken in both sitting and the supine position. Fundus examination, the patient was dilated with 5% phenylephrine and 0.8% tropicamide to carry out fundus examination. Left eye, media was clear. Optic disc was vertically pink with healthy disc and cup disc ratio of 0.5 with healthy neuroretinal rim with the distinct disc margins with mild tortuosity of vessels on the disc. And the vessel shows normal AV ratio of 2:3 with resolving soft exudate suggestive of diabetic macular edema, and background retina shows stable PRP scars all over the periphery. OCT examination shows multiple irregular hyperreflective foci with spongiform edema, which is suggestive of diabetic macular edema. Cornea and glaucoma opinions were obtained, and patients was started with 0.5% moxifloxacin eye drops 4 times a day, 0.5% homometropin BD, and 0.5% timolol eye drops OD. Tablet acetazolamide 250 mg BD was given along with pantoprazole 40 mg OD. Then the patient was planned for Ozurdex implant removal. Patient was shifted to block room, and left eye subtenon block was given and taken inside OT. On table, surprisingly, the implant was not visualized in the anterior chamber by the operating surgeon. Then the surgery was deferred, and the patient was advised to be in sitting position. This is an intraoperative anterior segment photograph which shows the missing implant on table. So, left eye indirect ophthalmoscopy examination shows the Ozurdex implant in the vitreous cavity, and also in 1 month and 3 months follow, the disintegrating Ozurdex implant was seen in the vitreous cavity. Now, moving to case discussion, it's an article by Ozgen and Koyotsuki et al. On anterior chamber migration of Ozurdex implant shows multiple case reports. This is case report number 1. 61 years old male patient with proliferative diabetic retinopathy who underwent PPV and endolaser in both eyes due to bilateral intravitreal hemorrhage. On fundus examination, laser scars were seen in periphery and macular edema with microhemorrhages seen in both eyes. So, the dexamethasone implant was given for the patient. This is the photograph of the dexamethasone implant to treat the macular edema, and this is a OCT picture showing the persistent macular edema. So this is a case report number 2. 79 years old women who underwent left eye PPV, NSFIOL for complicated cataract surgery. FFA imaging showed macular edema of the left eye, and dexamethasone implant was done. The implant appeared in the anterior chamber 15 days later. After pupillary dilatation, the patient was placed in the reversed Trendelenburg position, and the implant was directed into the vitreous cavity by corneal manipulation with a sterile cotton tip applicator. The patient was advised to sleep in 45-degree upright position until the implant degraded. At follow-up examination, the dexamethasone implant implant had degraded and the cornea was clear. So this is the picture showing the dexamethasone implant, and the clear cornea was seen and follow-up after guiding the dexamethasone implant from the anterior chamber to the vitreous cavity. So this is case report number 3. A 73 years old male who underwent left eye PPV with esophageal for traumatic cataract. The implant was observed in the anterior chamber of the left eye on slit lamp examination during follow-up. Using a 23 gauge catheter and anterior chamber maintainer, the implant was removed from the anterior chamber and repositioned in the vitreous cavity. Then the dexamethasone implant appeared in the anterior chamber again the next day. Then the implant was removed from the anterior chamber by aspiration by 23 gauge catheter. And follow-up examinations revealed corneal edema and features of bullous keratopathy. The patient was evaluated in the cornea clinic and underwent keratoplasty 8 months later. So this is a picture of dexamethasone implant in the anterior chamber, and this is a picture of bullous keratopathy which is observed in the follow-up time after dexamethasone implant that has been migrated to the anterior chamber and twice and was removed with 23 gauge catheter. So why this case? Anterior chamber migration of Ozurdex implant is a potential uncommon complication in eyes with compromised lens capsule prior to vitrectomy and/or iris defects. Corneal endothelial decompensation is a more serious complication resulting from migration of implant into the anterior chamber. Anterior chamber migration of Ozurdex implant in PCIOL patients with zongular dialysis is very rare. Very few cases of implant migration in eyes with esophageal have been reported. So the Ozurdex implant is a rod-shaped biodegradable dexamethasone implant of 6 mm in length and 0.46 mm in diameter injected into the intravitreal cavity by using 22 gauge needle. It is effective in treatment of macular edema due to retinal vein occlusions, diabetic macular edema, and non-infectious uveitis affecting posterior segment. After implantation, the Ozurdex polymer matrix releases 0.7 mg preservative-free dexamethasone into the intravitreal cavity and degrades into glycolic acid and lactic acid. The most common complication reported after dexamethasone implant is increase in intraocular pressure, which peaks at about 3 months. Other complications include corneal endothelial damage, secondary corneal edema, implantation in lens, and dislocation into anterior chamber. Migration of dexamethasone implant into anterior chamber is a very rare complication that can be managed by directing back into the intravitreous cavity or by removing it from anterior chamber through corneal incision. So the take-home message is utmost caution should be in mind while advising intravitreal implants in patients who had underwent previous esophageal and PPV surgeries and also with history of traumatic cataract. Thank you. I would like to thank Dr. MP sir for giving me this case and guiding me throughout my presentation. Thank you.